He then moved across to the US, to Texas, Florida, and Ohio. He completed his pediatric neurology fellowship there. And he was working in his return from the US in Al Mafraq Hospital. As I said, towards the end of last year he joined us. He has interests in pediatric epilepsy, pediatric headache, he does Botox clinics, and today he's talking about non-epileptic paroxysmal disorders in children, which is quite a common problem, not only for general pediatricians, but also for pediatric neurologists. So I'll hand you over to Doctor.
So, can you guys hear me? This one, can you hear me? Can you hear me well? So, thank you very much, Dr. for this very nice kind of introduction. After listening to several lectures, I advise everybody to give several lectures. It looks like it's the heaviest step. Today we're going to talk about very common problem, I face and a lot of my colleagues face in the field of pediatrics and in the field of pediatric neurology. As you can see here, this is me, and this is our website. And we're going to go for the one. Okay, so epileptic seizures, this is one of the things when we see an abnormal movement or twitch or shake, the first thing comes to our mind, is it a seizure or not? So the International League Against Epilepsy defined the seizure as a transient hypersynchronous neuronal discharge. It is that is associated with clinical manifestation. And the main differential diagnosis of paroxysmal event is it epilepsy or it is not epilepsy? Is it a seizure or is it not a seizure? Now, the non-epileptic paroxysmal events, defined by International League Against Epilepsy as a clinical manifestation presumed to be unrelated to abnormal and excessive discharge of a set of neurons in the brain that include brain dysfunction or pseudo-seizure, which is non-epileptic spell. Now, paroxysmal event, life is easy. If you have a paroxysmal event, is it epileptic or is it non-epileptic? Okay. So what you need to know, is it epileptic or is it non-epileptic? The non-epileptic, there's a wide range, psychologic, organic, physiologic. There's a lot of these abnormal. Now, let's go to case number 1. This is a 6-month-old kid who was, as you see in the video, the kid was noted to have recurrent spells of hyperextension of the trunk. Yes. Yeah, so you see a hyperextension of the trunk, okay? And this is started, 6 months, or let's say, 3 months, and was seen at 6 months, was referred for further evaluation at the primary care physician. Now, looking at this video and looking at the posture and knowing it is intermittent, what is your next step? I want to do an EEG. I'm a neurologist. All what I did is these ziggly-wiggly lines, so I will do an EEG. I want to do barium swallow because this looks like a reflux. Okay, the patient is hyperextending his neck. Okay, I want to do ambulatory EEG to capture the spill, the gold standard, or I need more history, or I want to send him to City Hospital ER to see Dr. Kash, and he later on can call Dr. Hamza to see him. So, Dr. Kifar, what do you do? More history. Excellent. Whenever you have a side effect and you see dilantin, always this medication is most likely the cause of that side effect. Whenever you see more history, please go for that, because almost always you're going to be right. Okay, so this kid was born with macrocephaly, the head was large, and he has episodic encephalopathy-like rupture. It started at the age of 6 months when she gets sick or during febrile illness. Okay, that's more of a clue. Now, your next step in the evaluation, listening to the history, I will do very long chain fatty acids, urine organic acid, acetylcarnitine profile, transferrin isoforms, urine amino acids, or do Murphy approach, one of them. And no one would say you are wrong. Okay, Cash, what will you do? You have a 20% chance here. Choose whatever you want.
All of them.
All of the above. Excellent. You know, I would probably have done that if I did not listen to the history. But what I would do, I would go to urine organic acids. Okay? Now, your diagnosis, we did the urine organic acid, and the urine organic acid came back abnormal. The patient has macrocephaly, intermittent episode of hyperextension of the neck, and episodic encephalopathy-like picture which points to underlying metabolic disorder, right? So, your diagnosis is axial dystonia secondary to glutaric aciduria, methylmalonic acidemia, congenital disorder of glycosylation, rhombocephalosynapsis, okay, and GERD. That's good. So this patient, you know, what he was having axial dystonia secondary to glutaric aciduria. Now, I love neuroradiology, so in each slide or each case I'll probably throw a case of neuroradiology for us to look at to see how much is interesting neurology and radiology. So not everything shakes the snake. This kid has axial dystonia secondary to glutaric aciduria. Type 1. Because he was having episodic like picture that started at the age of 6. He was having macrocephalic at the baby. Methylmalonic acidemia, it would start usually in the neonatal period. Congenital disorders of glycosylation, where we do the isoforms, usually they are hypotonic. If you do the MRI, they will have a small cerebellum and small pons, okay? And rhombocephalosynapsis has nothing to do with this diagnosis. So, rhombocephalosynapsis basically is a fused cerebelli. The cerebelli are fused together, and this is one of the uncommon cases we see it in neuroradiology. Okay? Nice. Now, glutaric aciduria type 1, it's an autosomal recessive. It is deficiency of this lung enzyme. Usually they are macrocephalic at birth, so if you see that, you should be hyper-alert. 2 types. One type, recurrent encephalopathy. Another type is slow progressive, that they come like a CP-like picture. Or, when you do the brain MRI, it shows acute restricted diffusion in the striatum. As you guys see in the picture here, this is diffusion-weighted image in the MRI. The white spot, when you see white, that's means there's infarction or restricted diffusion. So this is how we diagnose infarction. It's very simple. You do diffusion-weighted images, you will see the bright spot. This is most likely infarction. Okay? You do urine organic acid, high glutaric, 3-hydroxyglutaric, glutaric, and acetic acid in the urine. Very simple. And usually the treatment is more of a supportive, especially if the cases are not very advanced. Okay? Now, when I look at the MRI, I love the MRI myself. You know, I spend a lot of time reviewing all my patients to the extent I came up with what we call MRI oath. I swear to God, I will look at every patient MRI, the whole MRI, and nothing but the MRI. If the resident come to me and he told me, you know, the MRI looked abnormal, the next question from me, did you look at the MRI yourself? Because no, I can't tell you how much, how many times I look at the MRI, it's reported normal, it's abnormal, and this is not cerebral-zingy because of the very small, you know, number of pediatric neuroradiologists trained in the world. Now, MRI ABC, okay, we are deviating here from the mainstream. Every MRI is abnormal, until proven otherwise, guilty until proven innocent. This is make you look left and right, up and down, you know, back and forth at the MRI to make sure you are not missing anything. Look at the whole sequences, okay, and look at the sagittal, coronal, and axial, okay. MRI is displayed with its twist and turn. So if you find an abnormality, please rest if you must, but don't stop. You know, say it in here. Stop it, okay? This is a different language. Why? Because a lot of the time, dual pathology is very common. You might see infarction, but you forget about the brain tumor. And that's very common. We see it. Now, bias and prejudice are attitudes to be kept in hand, not attitudes to be avoided. Which means, when I do an EEG and I see right temporal area abnormality, when I look at the MRI, you know, I have to be a tunnel vision. I look at the whole MRI and I focus on the right temporal area. Because this is where most likely is the pathology, especially in epilepsy. Now, if I don't look at the MRI, males and females have equal brains, so that's strong, what is up there. And please stay safe in the MRI suites, because these are real cases, you know, and these are real, you know, photo for people flying to the MRI machines. Because it's electromagnetic, they pull them to the machine. Now, with this patient, kid with Leishman syndrome, I want to show you guys what's he doing. Look what's he doing. He's sitting there, and all of a sudden look at the left hand, to become, whoop, hit his face, right? Keep hitting his face. And it happens all during the day. So, your next step in this patient, I would do a head CT, okay? It looks like a dystonia. I will do a video EEG to capture the spills, okay? Brain MRI, brain MRA, MRV, okay? And ambulatory EEG, and no more history here, or no more, none of that, all of that. So, the first thing when I have, as we said, the first thing that comes to my mind when I see things abnormal, is it seizure or not? So we'll go for the money, we'll go for the EEG, right? What is the difference between video EEG and ambulatory EEG? Video EEG, I hook up the patient 24 hours or 48 hours for the EEG, and I send them home. I capture the event itself, right? Because interictally, you might have normal EEG in 50% of kids. So when you capture the event, there's no video. The video EEG, you put them in the hospital and you put the video in. So this is the gold standard to diagnose non-epileptic, paroxysmal non-epileptic events. So who would say brain MRI?
According to your rules, a must.
Yes. So yes, according to my system. So I will go to video EEG to capture speed. You want to make sure, is it seizure or not? Okay? And to show you here, this is what we call the MRA. We look at the magnetic resonant image angiography to look at the vein, the arteries. The MRV to look at the veins. So these are two different MRI modalities. Okay, so we'll go for video EEG to capture spills. Dr. Fadl, would you go for that? Okay, sure. Now, your diagnosis, infantile spasm, okay? Familial kinesogenic dyskinesia. You know, in neurology, we love big names, complicated names. That's, you know, all what we do. Familial non-kinesogenic dyskinesia, self-mutilation, none of the above.
None of the above. None of the above.
None of the above. Who said the self-mutilation?
Yes.
Bingo. So this is self-mutilation. Now, if you put the gun to my head and tell me, Dr. Hamza, as a child, simple country epileptologist, what do you think is this? I will tell you this is seizure. Man, this is could be myoclonic seizure. But when you do the video EEG and you capture the smell and the EEG is absolutely very normal, you know that this is not a seizure. That's the benefit of video and ambulatory EEG. Okay? So this is self-mutilation, which is extremely common in case of Leishman syndrome. Okay? Now, treatment in history. In the 15th century, they used to do cauterization. Ancient China, you know, in our culture. In the Renaissance, if I'm saying it right, they used to do stone cutter. It's very common practice. Patient with epilepsy, they open him, they have a knife, and they try to open his brain to take the stones out, okay? To treat his epilepsy, and they were very popular in the community. They called it the stone cutter. We have came long way since then, guys. So now, Kashif, you are not allowed to answer this because you saw this before. Now, what do you guys know? What's this? Colosseum. Okay. And what did they use to use it for? Gladiators, human against a human, human against animals, animals against animals. Okay. And they fight to death. You have to fight. You either will be alive or dead by the end. And when they die, they drag them through these doors, right? And while they're dragging, we see a lot of people lined up here and, you know, collecting their blood. Do you know why they are collecting their blood? And Kashif and Dr. Kithar are not allowed to answer. Anybody has any idea? Dr. Zain? Yes, perfect. Because they want to make sure they are not having glycemic. Because this was the drug of choice of epilepsy or falling sickness at that time. And Don't get scared. I don't do this to my patients. So send me patients. Now, the treatment that can be helpful in this kid is Risperdal, botulinum toxin, Zoloft. I should have put Cipralex. None of the above, only 2 and 3. Chances are always 20%.
None of the above.
None of the above. Perfect. So for me, I would go for Risperdal because this is very good for self-mutilation. Okay? Because these kids, they can aggravate themselves to the extent they can lose their fingers, their nails, and can be really quite severe problem. Okay? Now, Leishman syndrome, deficiency of this lung enzyme. It should be less than 1.5% in the RBC or culture fibroblast. High uric acid in the urine and in the blood. Okay? And chorea and athetosis may develop later, and we'll talk about chorea and athetosis. Self-mutilation is cardiac. Allopurinol may decrease the uric acid level. Aldopa, tetrabenazine, and Risperdal may help self-mutilation. And the gene, now we are in the era of genetic evaluation. HBRT1 molecular testing is available. Perfect. I want you to look at this guy. Apparently he is not a pediatric, but he's closer to geriatric. I want you to maybe just turn the volume on, guys, because he will be talking to this guy. Can you hear? I think this is not too good. So I'm going to turn it on again, guys. I want you to hear what's he saying also. Can you hear? Okay, so this patient, he was saying, making funny noises. He also tried to, say bad word like, shut up, all of a sudden, and he would always say, all the time. And the guy, the interviewer asked him, did they, polite, of course, did they kick you out and did they let you attend your graduation for your son because you do all this stuff? He said yes. So what he's doing is making inappropriate word. Okay? He is doing a lot of, and saying, shut up, all of a sudden. So I would love you guys to hear what he's saying, but technically is not possible. Now, what do you want? More history, brain MRI, EEG, ambulatory PET scan. More history, yeah, you got it. So we will go ahead and do more history. This patient has been having this abnormality to control his vocal or vocalization and his movement over for over 1 year. Okay? So, your diagnosis is Tourette syndrome. Your diagnosis is frontal lobe epilepsy, stereotypical behavior, complex motor, Tourette syndrome, or aesthesia abasia. Tourette syndrome. But this is not the question. The question is, what is aesthesia abasia? Does anyone know what is aesthesia abasia? Aesthesia abasia is more of the psychogenic gait. If you put aesthesia abasia, and you see people walking, and they are shaky and doing something like preternatural gait, that's what we call aesthesia abasia. So Tourette syndrome is basically, what's the diagnosis? What is the difference between complex motor and vocal tics and Tourette syndrome? Duration. Is that 12 months? More than 12 months. Believe me, guys, technology is really, really simple. Okay. Now, medication that might be helpful in this case: clonidine, tobemax, Neurontin, all of the above, none of the above, one and two. Clonidine, excellent. So clonidine is one of the medications that can be very helpful, and there's only 2 places available in Dubai. Okay. Now, this is a case I saw in my clinic, and I would thank my colleagues for sending me all these fancy dandy, not complicated cases, and very simple, easy family to deal with. This is a 3-year-old girl with sudden onset of fear who would run to her mom, close her eyes, and if there's nobody around her, she would put her head down on the floor and close her eyes for a few minutes and vomit, and then less than 5 minutes she's back to normal. Your next step in the diagnosis or the evaluation of this patient. Did you guys capture the picture? So all of a sudden, severe onset of dizziness, close her eyes, and she will hold tight on her mom, and if there's nothing around her to hold on, she would lay down, put her head on the floor, and profuse vomit. Your next step, EEG, brain MRI, call the child medicine call, more history, physical exam. We say this always more history, right? No loss of consciousness, so she does not lose her consciousness. No thought colors, no headache, no post-ictal state, no sphincter control loss, no family history of similar attacks, but her father has motion sickness, no hearing loss, nor any tinnitus. Physical exam is normal, and these episodes are not positional. MRI and EEG both were done, and where normally your diagnosis is basilar migraine, labyrinthitis, episodic ataxia, all of a sudden the kid get the ataxic, benign paroxysmal vertigo of childhood, benign positional vertigo. Any idea? 4, we have here 1 vote for 4. 4? Perfect. So that is what we call benign positional vertigo of childhood. And it's very uncommon, but it can be very, very scary for the family. Now, it was described first in 1964. It is sudden onset in 95% with fear and anxiety in the child who refuse to stand. So refusal to stand not always means that there's a problem with the legs. They refuse to stand and they grasp somebody, typical representation, never loss of consciousness, frequent vomiting, less than 5 minutes, trigger factors, swings, random. So now 83 has a family history of motion sickness, and the dad of this kid I saw has motion sickness. I told them it is benign paroxysmal vertigo, and after that they disappeared. Now, this is more of a flow chart, to tell you how to monitor, how to differentiate these things, and to go. It's more of later on if you want to use it in the clinic. Now, there is a criteria for benign paroxysmal vertigo: at least 5 attacks, multiple opposite severe vertigo. They can kill you, occurring without warning and resolving spontaneously after minutes to hours, and normal medical examination, audio and vestibular function between attacks, and normal EEG. Now, that is Salem witch trial. Does anybody know what is Salem witch trial? Yeah, these people in the 16th century, people who had falling sickness or epilepsy, some of them were captured and they were back to the court, and they were convicted of doing witchcrafting. So some of them were beheaded, some of them were stoned to death, and some of them were imprisoned, and some of them were burned alive, as you see in this case. Okay? So that's what we call Salem witch trial. It's more of history about epilepsy. Now, I want you guys to pay attention to this kid. Now I have to turn on the volume off, because they will tell you the diagnosis from the first minute. So this is a kid who is 3 or 4 years old. And I want you guys to pay attention to what she is doing. She would stand up from the chair, okay? She's having, abnormal jerk movement, okay? She fell down. And watch how she's walking, okay? All right. Now, this patient has chorea. She had ataxia. This is a clinical description. I'm not asking about the underlying reason. Wide base, unsteady gait. She had rapid jerky extremities movement. All of the above, slow riding movement. Okay. So when you look at her chair, she was having abnormal jerky movement, right? So that's abnormal jerky movement. Abnormal jerky movement is chorea. This is the definition of chorea, right? And when she was walking more of a wide-based gait. Wide-based gait is the definition of ataxia. So the answer would be all of the above. Slow riding movement is what? Is apoptosis. It's very important for us, for me, it's really important to know what you are looking at. If I do describe what you are looking at, you really can't start the workout. It will be very difficult. Look like, black magic. Now, your next step is more history, brain MRI, anti-DNAs, B and ASO titer, neurotoxically, serum copper and cellular plasma level. Neurotoxically. Good. Anybody else? Serum copper. Serum copper and cellular plasma. There. We always say, whenever there's a more history, you want to go for more history. Please, okay? So more history. This kid has a history of a progressive jerky movement chorea and abnormal gait. 1 year ago, that started 1 year ago, and her dad started to have the symptom around the age of 35 years. And he was diagnosed to have something, and this kid got the same thing. Your diagnosis: Huntington disease, Wilson disease, Sydenham chorea, Grady-Negro syndrome, and none of the above.
Number one, I think that there's discoloration of cornea.
I don't know. I have to be honest. As a blind examiner here. Okay, so Dr. Khan. Yes. Good, but this is not the question. The question was the Grady-Negro syndrome. Grady-Negro syndrome. If you get the answer right, you're going to get another answer. If you got it wrong, that's right. So that is absolutely Huntington disease. Now, what is the Grady-Negro syndrome? This has nothing to do with that. Absolutely. It is more of, something, deja vu came to me and I throw it in there. Grady-Negro syndrome is P+ epicytis. It's a neuroradiology with abducing nerve palsy, and that go through the dural canal, and sometimes it's associated with orbital pain secondary to trigeminal involvement. Now, what I want you guys to look, this is the beta segment of the carotid artery, right? This is the P+ apex here, and look here with contrast. Looks abnormal, enhancing. So this is P+ epicytis. Dural canal is there. Mickey cave, where the fifth nerve go through, is a little bit out. So that is what is Grady-Negro syndrome. Sorry, I go south all the time with some of the suggestions. Okay. Now, next step: genetic counseling. Start with the key, high dose steroid, IVIG, observation. None of that. What do you do? So, perfect. So we'll go for genetic disease. This is one of the saddest diagnosis you can ever do. This kid is like 3 or 5 years old. She's developed Huntington disease. I saw 2 cases, like this. It is autosomal dominant with hyperpenetrance. Movement disorder plus and. This is not a type, it's a plus and. Cognitive and psychiatric manifestation, quite common. You will pick up this patient from the prison because they have a lot of psychiatric problems. And when later on they become aggressive, later on they find out they have Huntington chorea and the other disease that can come, common in the prisoner is Wilson disease. These two, if you present and see one of these, just circle that option. Juvenile form is less than 5% and it starts at less than 21 years of age. And its expansion of trinuclear repeat, treatment symptomatic, chorea and antidepressant if it works, and behavioral atypical antipsychotic because this can be quite hard. Okay? Now, that's another kid. This is very simple case. Kid's 2 years of age, he was running at home, chasing his the ball, and all of a sudden when he tripped over, hit his head on the floor. Then he came to me, become very stiff, then he fall down. Post-ictal a few minutes, then they shipped him, they took him to the hospital, okay, and then he back to normal. They reassured them, they showed Takashi said, you're doing about it, life is good, go home. The family were quite happy with his approach, but unfortunately 2 months later he was jump-started and jumped off the chair, hit his head on the floor and become very stiff and went unconscious for a few minutes and back to normal. Okay? What is your next step? Brain imaging, EKG, EEG, iron panel, echocardiogram, reassurance. Reassurance. Good. Hashim, you said what did you do to advise?
Reassurance.
Reassurance. Good. He reassured them the first time, but the second time I told them to go ahead and do iron panel. Your diagnosis: reflex epilepsy, breath holding skills, long QT syndrome, called Dr. Muhammad paroxysmal attack, none of the above.
It's number one, is that the same reflex anoxic seizure?
Reflex anoxic episode, which is we are talking about the paroxysmal attack. That is paroxysmal attack. Typically, the kid with any painful stimulation, they lose their consciousness and become very, very, hypotonic, and they lose their consciousness. Usually, it's very common in with no iron. And we still remember one of our, high maintenance attending, high state, when I told him on the floor, can we do iron panel on this kid? He looked at me, and why do you want to do it? It can be associated. It was too late for me to withdraw, so I told him it can be associated, and it was no iron. It's very common. I have 2 kids seen over the last 1 or 2 years, and the iron was low. So if you see this, do iron level. Now that is very interesting. I saw this kid 3 or 4 months ago. The mom, she works in MBC, okay, as the new physician in the private, where I said, we really have to be nice to her, we please them, you might be one day on MBC show, make you very popular. So the kid came to me, he was having abdominal pain, recurrent vomiting, okay, that has been going on almost 1 year, and he was seen by 2 well-known GI tract subspecialists, 1 pediatric GI subspecialist, 1 pediatric surgeon, and he was seen also by a well-known pediatrician, which is, I trust all of them. And he came to me on Tigratol, and the mom said, listen doctor, he is doing great for the last 4 days. The pain is gone. It's recurrent abdominal pain with vomiting. Now, he's doing great for the last 4 days, okay, but it's too soon to tell. If you hear this, what is going to be your answer? Stop Tigratol and do another EEG. Because he had an EEG, it was normal. But it was not ictal, it was interictal, between attacks. Keep Tigratol and do ambulatory EEG, okay, to capture the attack itself. Brain MRI, head CT, all of the above. What would you do?
So we can call and do another EEG, and this is most likely a abdominal migraine.
Excellent, lovely. Who would agree with Dr. Fadl? I agree with you. But if the patient is doing well, don't rock the boat. If a patient comes to me on Dipakine or in a medication, Salvia, for example, and he's doing great, I don't change it, even though I hate the hell of Salvia, but I don't change it because he's doing great. So I said, you know what? Let's not change anything. Let's keep him in Tigratol. I'm glad he's doing fine. Okay, make sure you pay, the bill on your way out. And she did. The dad, unfortunately, looks like this. And he's very innocent, simple Jordanian guy, non-intimidating. I was not stressed at all. He did not have meltdowns. Okay?
He started toxic.
Huh?
He started toxic. Look at his eyes.
No, most likely you have not been to Jordan yet. When you go to Jordan, that's the next one. Toxicosis is the most difficult disease to diagnose in Jordan. Okay, so remember the guy, okay? Okay? Now, 5 days later, the mom called me, remember, she's in NBC, I'm really sweet talking here at the dad. We want to make some business, guys, okay? So, had another attack and his father called us. We brought him in and we switched him to Tubermax because, Tegretol, I don't like it as, abdominal migraine or as a prophylaxis for migraine. I hardly ever use it, okay? We started with Tubermax and we told the man, I literally told her, we need to do an ambulatory EEG on him. She said, it's not approved by insurance. I told her, you know what, we'll do it. If the insurance does not pay, you know what, we'll take care of it. While we are hooking him up to the EEG, he had an attack. And the way he was, this kid, I still remember this kid, he was doing like this. And he was crying, vomiting. I looked at him, I said, does not look like abdominal migraine. Now, if you ask me how abdominal migraine looks, I really don't know. But that kid did not look like abdominal migraine. It looked like more of colic. I talked to the GI, he was my friend, pediatric GI, and he's one of the best. But are you sure there's nothing here or there, X-ray, stoma here? He said, no. Everything is fine. So what I did...
Sorry, have they done plain X-ray of the abdomen?
Believe me, they did every test known to me related to GR. Every single test. I did not tell you what the are. So we did that. We captured the episode during the attack, so it is not abdominal epilepsy. We will do this out because this is one of the diagnoses. I said this is not abdominal epilepsy. Let's go ahead and switch him to Tubermax because I don't like Tegretol. So I switched him to Tubermax. I got the answer, and then sweet talk the father. Okay, remember, you need to really sweet talk this guy, okay? And sweet talk the father, and then they disappeared. Called the mom 5 days later. Hi, how are you doing, mom? How's life? He's doing great. Thank you very much for being so nice with us. I did not tell him when is going to be my interview in NBC. I kept this myself. Then all of a sudden, guys, after seen by pediatric GR, 2 adult GR, pediatric surgeon, and the lucky child neurologist, the patient disappeared, and he went to King Hussein Medical Center, and I don't know what the hell they thought of it. They did the Meckel scan of this kid, and he had Meckel diverticulitis, presenting as recurrent abdominal pain in his stomach. So after that, it's a very uncommon presentation of very rare disease.
Had you had any episodes of GID?
No, absolutely not. And I don't know how did they think of it. I don't know. But honestly, when they came to me, they did every single thing, even endoscopy up and down. Okay? Now, out of my love for neurology and out of these cases, as I did this what you call, I love neurology. And I really do love it to death because, a lot of the time, you know what you are dealing with, but you are not sure you're going to reach for a diagnosis. So this is a poem written by me, okay? So I would say I love neurology, and guys, I want you to pay attention because in each, when we talk about this, it is all, I will tell you, it is all give you localization in the brain, okay? So I tell you I love neurology, love it to death. Without neurology, I would not have a breath. Without my neurons, I'll be deaf, I'll be confused, I will be stiff. Without them, we'll have a useless nose, I will not be able to smell even a rose. Without my neurons, I can't feel, I'll be blind, I will not see. Without neurons, lose my mind, I will be rude, claims in the pan, my thalami are my Wi-Fi. Without thalami, no ideas fly. Frontal lobes, keep my home. Without the lobes, I see a dark glow. Cerebral eyes, held by gate. Without the eye, I walk but never straight. My cords keep me alone. Without the cord, never on the road. Facial nerves help me blink. Without a blink, I can't have a wink. I make the lie, keep my fear. Without the fear, I love there's an ear. Please exercise, keep a healthy heart. It feeds my neuron, it keeps me smart. Please do me a favor, leave me alone, don't stress me. I need healthy neurons. So please help me, save my neurons. If you give me stat value from me alone. Thank you very much. Now let me tell you what huh? Neurologist? No, I would not be saying that. What I would say here, my thalami are my left eye. Because the sleep spindles are formed in the thalami. If you don't sleep well, you are not gonna, the eye will not fly. And frontal lobes, if you have injury there, you will be very depressed, okay? And we will make it and continue for the exercises, okay? Questions, guys, for me?
So, are you still hoping to appear on the NBC?
Well, no, I'm working now on
For poetry or for pediatric neurology?
I wish.
Thank you very much for the presentation. Marvelous.
My pleasure, thank you very much.